Oh, yeah. Hey, here we go. Hello. Hello, my name's Joel Dunning, and I'm here with Lorena Montes. We are officially the world's worst IT people, so I apologize for being a couple of minutes late, precisely 3 minutes late, which in the world of live webcasting is forever. So thank you very much for joining us. We're live here at EACTS 2023, and I thought I'd better give you a formal introduction. This is Lorena Montes. She is our brand new cardiac surgery editor, and the really exciting thing is that you are from Latin America. So tell us a little bit about yourself and where you work, and it's great to have you here.
So, yes, I'm Colombian. Actually, I was born in France, but then I moved with my parents, who are Colombian, to Colombia. And actually, I'm working at Bucaramanga, which is a small city, intermediate city in the northeast of Colombia. But interestingly, it has a lot of a big clinics, especially one for the heart, specialized on the heart, which is where I work. It's Fundación Cardiovascular de Colombia.
Great. Well, thanks a lot for joining us. And are you having fun at EACTS?
I am.
Seen lots of things. It's so busy here. So there's so much going on here. It's been absolutely packed, and it's day 2 actually. So day 1 was the absolutely infamous Techno College, the Techno College that really I think is the best sessions in the world. Really, they've been doing it for so many years. Really, they do so many live operating, which is what I find most exciting. So this year they had 3 streams, 2 of which were thoracic and cardiac, and then they had a robotic stream as well. So the cardiac one, I think, was the standout one for me. The best one as well was they had this wonderful aortic valve session, and they had a live hemistenotomy Bo Yang procedure, the Yang procedure, doing an aortic enlargement. And we actually just interviewed Dr. Conradi, who was the surgeon that did it. And but I did hear it was quite amusing because he was there live with doing the cutting, and then Bo Yang, the guy that invented this technique, was cut more, be more brave. So the poor guy, with hundreds of people watching him, having to sort of, do exactly what the inventor of a procedure had to do. It was pretty crazy, really. So, but it was very successful. Everybody had their 3D goggles on, and they saw it all in 3D. And a very successful case. They also were talking quite a lot about patient prosthesis mismatch, how important it is, really. So did you catch any of that, or what were you doing?
I wasn't in Techno College.
Yeah, but it was really good. And Bo Yang's actually got a video on CTSNet all about how absolutely he thinks it's so important to be doing no patient prosthesis mismatch. He enlarges his roots to crazy sizes, 27, 29 millimeters every time, to reduce that mismatch. He's very convinced that is the way forward. But I don't know if you've done any Manugians and Nixes.
I have actually 2 days ago. I did a Manugian, and I was willing to do a Y technique that is the Professor Bo Yang is doing. But I think it's very reproducible, the technique. It's easy to do. So and he's getting a lot more of large annulus than any other technique. So I think, and you don't touch the mitral valve. That's the most important thing. So I think that will be very successful.
Yeah, absolutely. So as we say, Bo Yang, we've done a little video with them both, and so we'll be posting that pretty soon. That was absolutely brilliant. There are a few other really, really good 3D operations. One of the really impressive one was Mario Di Eugenio. He did a frozen elephant trunk, and there's this really new thing. It's called the T-Next Thoraflex frozen elephant trunk, and I hadn't seen this before particularly, but actually what they've done is they've moved the 3 arms of it. Instead of having 3 separate arms going to the innominate, carotid, and subclavian, they put them all together as a sort of trifurcation. Have you seen this?
I saw the designs that they do. He has like drawings of it in the Techno College, so I could see the drawings.
Yeah, absolutely. And it makes a lot of sense, really, because this graft, this makes frozen elephant trunks much more easy. And the real particular use is because it's so distal, you can put your crust clamp on much more distally. And also, if you want to put a wire in antegrade, suddenly the angle's not down and up, it's a much straighter attack. So I thought that was really interesting. That was a really great one that was shown there. So Mario Di Zanio did that presentation. T-Nex Thoraflex was what that was called, which I thought was great. The other really good highlights there was Piotr Sawalski, president of ISMIX, was doing some minimally invasive CABGs robotically. And the other thing that blew my mind, they were doing loads of different operations from different operating theatres all over Europe. They're in Berlin, they're all over the place. So, I mean, mind boggles as to how they organised that, but well done, EACTS. They did such a great job with that. And then in the afternoon, they did a mitral valve repair with cryoablation. Dr. Kempfert did that. And he had a really cool novel suturing device. So do you do any minimally invasive mitral surgery?
Yeah, we do.
Yeah, how do you tie your knots? Have you got a core knot or fingers?
Doing it.
Yeah,
with the pusher of minimally invasive surgery.
Well, I think that's about $700 cheaper than these devices.
Yeah, that's the reason.
But yeah, no, if you want to save 3 minutes, then buy a $700 device. And there was one of those on show. So that was really cool. We really enjoyed that. Just of note, we are actually in EACTS right now. I just wanted to show you. We are here with our little booth, and there's everybody walking by. We've got our EACTS booth there. So it's pretty noisy here. So apologies if it's a little bit too noisy, but we just like to be in the thick of the action, really, for this podcast. And let us know, is this a good idea to do live podcasts at conferences? Maybe we'll do a few more as we go. And I've been bumping into a few people who are fans of the podcast. So if you're one of our fans, thank you very much for listening in. And that's great. We're doing them every single week. The thoracic session as well yesterday was really, really good. Isabel Opitz was there, and Claudia Cavitzel doing lung volume reductions by bronchoscopic and surgical lung volume reduction. I think they gave us some really great hints and tips how to extend the criteria and how to sort of really get the best out of those. I think they are quite difficult procedures. The endobronchial, certainly they fail a lot. You need to know when it's going to work, when it's not going to work. They gave us some good hints and tips with that. And also on the surgical side, who are the right ones to do? And certainly in my practice, we try and stick to the heterogeneous, really bad, khaki, horrible lungs at the top. But they were saying, you can get the more homogeneous people. But do you do much lung volume reduction in South America?
With thoracic, I really have no idea.
No idea.
In South America, it's different. And in Europe and United States, we do cardiovascular. And thoracic are completely different, completely separate specialties.
Yeah, well, we're going to talk to you a bit later about LACES, about the Latin Cardiothoracic Society, and we're going to get very involved, hopefully, with LACES and CTSNet, really profiling this wonderful society that actually gets some really good viewership. And you've got a brilliant annual meeting, haven't you, as well?
Yeah, we did our first annual meeting in the Foz do Iguaçu like a month ago, and it was a success, complete success.
Yeah, wonderful. So the third stream at EACTS yesterday was also a really, really good robotic session organised by Richard Milton. He had loads of robots there, Intuitive obviously sponsoring, and not only did they have the Intuitive robot, they also had their iron bronchoscope there as well. So some people getting their very, very first views of the iron bronchoscope. Obviously the robotic session was of cardiac and thoracic surgeons, all the rich ones anyway. So and so that was really, really good. One thing we didn't see was any other robots. So no Versius, no Medtronic, but maybe next year, maybe the year after, we'll be seeing the avalanche of new robots coming out. Do you get many in Latin America, robotic surgery?
No, actually, no, not that much. It's too expensive, but we are trying. So at least in Colombia, there is one center that is trying cardiac surgery with robots in Bogota.
Yeah, great. So, and today, what have we been doing today? Well, the very first first session was started at 8 o'clock, and they have started something called the President's Choice. Now, the President's Choice abstracts are the top 5 abstracts by voting in the whole conference, and they've had more abstracts submitted than ever before. They've literally had proper thousands, so they had to whittle them down, and this was the top 5. So in no particular order, they had a really interesting registry of 3 decades of the European Fontan Registry, 3,200 patients having Fontans, mainly for pulmonary atresia or transposition, but really young kids having these procedures, and they showed some of their early results, basically saying, you know, an extra cardiac Fontan was probably the lowest complications, but really, really good. 30-year data, really long. That was nice. The second one that I thought was really interesting, got massive high voting, was something called breathenomics, a word I've never heard before, but some of you may have seen these wacky YouTube videos of dogs being able to smell lung cancer, and basically they have created a kind of computer version. They've been able to find a gas chromatography version of taking your exhaled gases, and they took a load of cancer people, a load of people without cancer, 85% sensitivity in telling if you can have cancer. That's pretty crazy, isn't it, really? Yeah, so that was one of the top 5 abstracts. There was another really good one on moderately dilated type A dissections in young patients. Obviously, this was University of Pennsylvania from Joe Bavaria. 500 patients, looking at people that either had aortic root reconstruction when they had a type A dissection or had abentals. And actually, out of these 500 patients, they were saying, you know, just doing abentals was maybe had a slightly better outcome. And then the other thing was that they were saying the criteria for total root replacement in the dissection should go down to maybe 40 millimeters in those patients. I don't know if you saw that at all, or what your view is in dissections when you replace the root, or do you just get in, get out, and
No.
Yeah.
So we try to be aggressive.
Yeah.
We have in our center a specialist for aorta, and he's pretty aggressive. But when the specialist is not there, we try to replace the root or resuspend the valve if we can. It's better for our population not to have any anticoagulation or the possibility of a valve reoperation. So we try always to be aggressive, but to resuspend the valve.
Great. Well, that's great to hear. That's fantastic. And yeah, that was a really interesting take on that, which is great. So they were some of the late breaking sort of abstracts, which was really, really good. As well as that, there was a really wacky presentation a bit earlier this morning called by Bart Van Putter, and he told us about the SafeCab trial. Now, what's this? This is a laser-assisted anastomosis. Have you ever heard of this? Like, ever? This is crazy. I've never heard of this, like, ever. But they've got this clever laser called the excimer laser, and you can basically load it into a graft. You can kind of do the graft, then the laser just punches the hole into the vessel without interrupting flow at all. So it's brand new. It's actually being trialed in the Netherlands, and they were showing their first results of actually showing that it is safe. And I guess the logic of it is that if you're never interrupting flow, you're off pump, then you know you're never going to get some ischemia. But pretty crazy. So and something to watch, I think, for the future there, really, probably. That was pretty cool. There was a few other, one of the other top 5 abstracts was a very simple study, but Sweden had a database of 11,000 AVRs, and they simply looked at, are they on statins or not? And those people that were on statins had lower MACE, lower death, lower cardiovascular mortality. It's brilliant. So basically, super easy message, put your patients on statins after an AVR, they'll live longer. So do you do that?
It seems, yeah, we do. It seems logical.
It does seem logical, doesn't it? But I guess some people come to us with a simple lone aortic stenosis. Their cholesterol's fine, and so you kind of think, well, should they, shouldn't they? And I guess this study is basically saying just put them on a statin; they'll live longer. So that was a good one.
It's important to have this evidence, so everybody will do the same, and the guidelines will focus on that.
Yeah, absolutely. Then I think you were at the late-breaking trials, weren't you? So what did you see at the late-breaking trials?
I was a panelist, and it was a very interesting session, actually. So we have the mechanistic insights from the cast heart failure trial, and that was amazing to me because they are doing CABG in people that are have a LVEF under 40 and doing shock waves just
Yeah.
besides the CABG. So they did RCT and they compare a group control, which is the shockwave machine, just the proof put into the myocardial, but not giving shockwave, and the other group with shockwave. And what they demonstrated is that the LBEF actually improves in the shockwave plus CABG group.
Yeah, and what is this gadget that does the shockwaves? This is ultrasound or
It's
what was it?
ultrasound.
Yeah.
It's ultrasound.
Wow.
It's not like transmyocardial that we were talking actually before. You don't have to put a hole. They actually do the CABG and then they just take out the cross clamp and they put in the viable or hibernating myocardium the shockwave group.
Yeah.
They do MRI before, and then they did this comparison of they look why was this functioning, and they find that the bioglycan actually is has something to do with it. So they took some mice that had no expression of the bioglycan, and these mice will not improve the LVEF function, but the others will improve it very well. So let's see what importance.
Did they kind of say how it works? They got any idea how it works, or it just works?
No, they couldn't because of time, but
Yeah,
they are like doing all this part of genomics and all this very specialized part right now. But the shockwaves are actually functioning as far as what he showed. So
Yeah, amazing. Well, watch this space on that as a late breaking chart.
Then they actually we did had another session of surgery versus surveillance. They are doing this trial in Canada and United States about the surveillance of aortic aneurysms between 50 to 55 millimeters. And but they are just showing the funds to work between two countries and everything. They don't have yet. They are just finishing recruiting the people, but it seemed very interesting when we'll get the results.
Yeah, and I think they were just proving feasibility. They could randomize people because they're actually randomizing someone.
Yes.
Yeah, dear patient, would you like to have a massive, huge aortic operation or nothing?
Yep.
So, I mean, that must be pretty hard to randomize to, but they've done it. So well done them.
No, not
That's
done
great.
it at all.
But have they done a small group already?
No, it's a big group actually.
Oh, they've already
because
done
it's a big multi-center study with almost all centers in Canada and a few centers in United States in the East Coast.
Great.
And they have the big question in here is that they don't have sponsors from the industry. It's all government from Canada and United States. So it's very interesting because they could raise money for this funding from the government, not with any industry sponsors.
Wow, these first world countries, us from Britain and South America, we're all the same, our poor countries. So,
very tennis, a poor country.
Getting that way, that's for sure. And there was a late breaking trial about anticoagulation in mitral repair. What were they finding or telling us about?
So they actually compare anticoagulation versus no anticoagulation after mitral valve repair, and they found no differences.
Yeah.
So,
great. So we don't have to do it at last. Fantastic.
They are having some problems with it was a registry, so they had some statistical problems on that. But then they also compare the patients on anticoagulation between dogs and warfarin, and no difference too. So let's see that.
Yeah, great. Well, hopefully good news for the repairers that we don't have to send them home on any warfarin at all, because it's always crazy in my view, but there we go. And there was a little study, decent study about TAVR versus surgery, but looking at some quite long-term results, and you were there for that as well.
Yeah, this was very, very good one. So they all were good, but this one was with patients in Austria between 2008 to 2020, all the patients with TAVR. So they actually just see how well they were and the survival. And they show no difference. They did a propensity score and no difference. Yes, differences. Better TAVR than TAVR.
Yeah.
And
initially the same,
score,
but long term it became
long term different.
Yeah.
Better TAVR than TAVR, and propensity score better TAVR than TAVR. And then they did some analysis in patients between 2008 to 2015 and between 2015 to 2020, and the difference is still the same. So better TAVR than TAVR, even with better better TAVRs, if you know
Technology,
what I mean.
yeah.
Technology, better skills, better the improvement that we have in TAVR right now.
Yeah, and as always, they'll always say the technology is going to get better, but actually, it's long-term results we need, and that's what we saw with that. So that was a really good finding.
2008.
Yeah, no, really impressive. That's absolutely what we need. We've just had an honoured guest lecture. They were actually quite far-sighted, EACTS. They invited Benjamin Ignace Bundrurin, who you won't know because he's actually a doctor from Benin. He then became president of the Obs and Gynae College of Benin, and then he entered government, and now he's the health minister of Benin, so a doctor in the health ministry. And he told us all about how to kind of build up a healthcare system in the developing world. And I thought, well done, EACTS, for just bringing somebody in like that to be your guest lecturer. So really, really interesting. And there is actually an EACTS TV studio here, so which is pretty cool. They're doing some live broadcasting. I think you have to be registered, so you'd have to register to watch them, but we might see some of their videos afterwards as well, so check that out. And they've actually got a studio with an audience as well, so they're doing a few quite interesting things there, which I liked. Just coming up as well, there is a very soon to be done mesothelioma session, which I'm looking forward to. There's been a massive third shock wave of mesothelioma where the Mars 2 trial has just recently said it doesn't work. And after Mars 1 said it doesn't work, and Mesovat says it doesn't work. They're trying to get their heads around whether or not surgery for mesothelioma works or not. And so that's been pretty controversial. And we're actually going to talk to David Waller, who did probably about half of the cases in the Mars 2 trial a bit later. So we'll produce a full video. I'm talking to him tomorrow, but he's been presenting there. Obviously, very controversial. Lots of things like, did they use PET scans or not? Did they get the wrong patients? What was the quality of the surgery? Because, otherwise, if we don't believe this study, which I think was very well done, if we don't believe it would carry on, if it was well done, then that's the end of mesothelioma surgery, really, which is there a big mesothelioma problem in South America?
Yeah.
There's a lot of asbestos exposure, isn't there? And they probably even don't have the laws and rules that they do.
There are improving in Colombia, just like 2 years ago, the law changed.
Really,
only
just 2 years
only
ago.
2 years, yeah.
Yeah,
it was because of this woman that had a mesothelioma, and they exposed that in the Senate and all of that.
Yeah, and I hear you'd heard quite an interesting session about women's CABG in females. And what was that about?
Actually, very, very interesting this session. So it was improving CABG for women, because a call to action, that's the name of the session. So we had Mario Gaudino and Jennifer Lawton, Jolanda Kluin, Rashmi Yadav from Brompton that were actually speaking about this. And it was an incredible session. So they showed in all of the talks that women are actually being mistreated in CABG, if we see it, because we are having less multiple arterial graft, even though there's not that much evidence, and but the evidence that we have shows that we actually benefit more from the multiple arterial grafts than men. And so all the talks were showing this evidence that is very, very low. And Mario Gaudino actually showed the Roma, after the Roma ended, they just realized it was only 50% of women in the Roma.
Yeah.
So
they're starting Roma women, aren't they? So
they started the Roma women. Yeah. So the idea was to go to 2027 because of the recruiting the patients. But someone said, let's do this faster. Let's get into it. And a lot of associations. And now they have, like, in less than a year, 247 patients. So
wow, well done them. That's amazing, isn't it?
They are improving. They will probably finish before 2027 the recruitment of the patients that they need. Also, then Rashmi Yadav from Brompton did an incredible talk, like very touching talk about why women prefer women also as surgeons. And so she showed different cultural aspects, etc. And also the differences in women in the certain aspect as the coronary vessels and also the lima or the rima. So she was showing photographs of pathology of the lima from Caucasian adult men, adults, and from Caribbean women. And they were completely different, completely like a big artery and a very small calcified artery.
Yeah.
So it was very, very great.
Yeah, amazing. Well done them. That's
Yeah.
absolutely great. Fantastic. So lots more been going on. Just a few other highlights. The Techno College Award was given to the coolest invention ever. This guy, Hyun-Koo Kim from Korea. He's in thoracic surgery, we sometimes put in a little metal fiducial and then we can bring a massive, huge C-arm into theatres. He's got an endoscopic one. And it's like, what is going on here? Tiny little thing, 1/400th of the radiation, can fit anywhere. Crazy. So anyway, that won the Techno College Award. I think that was pretty cool. And there's a focus session just finished now where Hyun-Koo Kim from Korea has been showing the first 100 cases of the single port robots. So you think you're behind not having a robot at all. Well, now there's a single port robot, and they were presenting their first 100 cases in lobectomies, in thymectomies, and it was really mind-blowing. Their average time to operate on a lobectomy is only 180 minutes, which, that's pretty good. 130 minutes by thymectomy, all subxiphoid or subcostal. I mean, crazy. Technology is like, rocketing.
Like science fiction. But it's not. It's now. It's not the future. It's now happening. So
I mean,
it's great that we can see this in EACTS actually. That we are all like learning about this technology that is for everybody to apply.
Yeah, and that is part of coming here, I think, is you get to see all these new things, you get to make friends, you get to learn amazing things, and there's so much more to see. But I think that's probably all our time. I think we've had a half an hour little chat. It's been fun, hasn't it?
It is. And, if people can come to EACTS, we can tell them about it. So stay tuned with us.
And we'll be doing a few more interviews, and we're actually going to go and do a few interviews for some of your LACES members.
We are.
And what's our plans with LACES Interaction? Just tell us a little bit about LACES and how we're going to work together.
So LACES is the Latin American Cardiovascular and Endovascular Association. It's a recent, 4 years now since it was created. Victor Dayan is the president. We have a board. I am the chair of the Women in Cardiac Surgery Committee for LACES. And we did our first meeting because it was going to be 2 years ago, but we had the pandemic. So pandemics happened. So we had to do it this year in Foz do Iguaçu, which is in Brazil. So we have Spanish and Portuguese because we have Brazil and the whole other part of Latam, which speaks Spanish. And it was very interesting. We have a one-day session of 4 blocks. So we have coronary block with incredible speakers. We have Teresa Kieser. We have Patrick Myers. Then we have this session of aorta and the aortic valve. And we have also Ju Bavaria. We have Juan Pablo Maña. We had El Hamansi. And then we did the mitral valve session. And at the end, we did a heart failure session, which was kind of my area of expertise. So we did a hand-on session with clinical cases and the heart simulator, and it was incredible. The room all day was packed. So for us, it was a huge success. And what we want to do is to do some interviews to people that participated as speakers, attending, and also the people that planned it, just to see the perspective. How was it? How they felt? What is important for the region in Latin America to bring such personalities and such knowledge, and to show also what we were doing. We had abstracts too. I remember one from Peru that blew my mind. Between off-pump and on-pump, it was incredible. 1,000 patients. I mean, it's great to see these kind of things in Latam happening. So that's what we're going to do in a few minutes.
Yeah, great. So anyway, we've been having fun at EACTS, and we'll do a few more videos. And thank you very much for watching this little experiment of a live stream. So let us know what you think. It's also recorded if you couldn't catch it live. And we'll probably try this again, maybe at the SDS or something like that. So thank you very much for watching. And thank you, Lorena, for joining us. And we had a bit of fun. So great to see you. Yeah. Right. See you guys. Bye.